Hello friends, this is Dr. Anil Mahajan from Inspiring Minds. So today we are going to talk about the pathological aspects of the jaundice, which is very important topic, and how the clinical correlations can be made. So friends, since from the last video we discussed about the bilirubin metabolism. In the bilirubin metabolism, just for a revision purpose, repeat it again, that RBC destruction after the 120 days of lifespan goes to the splenic macrophages, goes to the spleen. There the splenic macrophages act, and after the further metabolization we get heme. So the heme is converted into the unconjugated bilirubin, and unconjugated bilirubin to transport into the blood, it needs one molecule which is albumin. But this unconjugated bilirubin has to go to the liver and it has to get detached from the albumin. And when this unconjugated bilirubin goes to the liver, it goes with the help of one molecule which is known as organic anion transport protein. In the liver, we already have the presence of UDP. Along with the UDP, unconjugated bilirubin combines and forms the conjugated bilirubin. Friends, this formation of the conjugated bilirubin occurs with the help of one enzyme which is known as UGT. It is UTP glucuronyl transferase with the help of conjugation reaction. So after that, this conjugated bilirubin goes to the intra and extrahepatic bile ducts. First it goes to the intrahepatic and then to the extrahepatic bile ducts and gets stored in the gallbladder along with the bile. So friends, it gets stored. Now whenever there is the contraction of the gallbladder occurs, whether we eat the food, fatty food and all, along with that bile, it comes to the intestine. In the intestine, friends, we already have the presence of our gut bacteria. This gut bacteria act over the bilirubin and forms one pigment which is stercobilinogen, which is responsible for giving the yellow color to our stools. And some of the 80% goes back to the blood and 20% goes to the enterohepatic circulation. In the blood, this 80% since 80% goes into the blood, since it is the, I told you, conjugated bilirubin, it is a water soluble compound, and from the kidney it secretes into the urine and forms a urobilinogen which gives a yellow color to the urine. Now the main point was to tell you this metabolism about the jaundice. I have told you in the last section, whenever there is a problem at the level of this enzyme UTP glucuronyl transferase, or till here there would be increased in the level of unconjugated bilirubin, then the person will have jaundice manifestation, or the jaundice can occur when this unconjugated bilirubin formed, conjugated bilirubin is formed, but whether there is a problem over here in the biliary system, biliary tree, or intra and extrahepatic bile duct, so that it would get any obstruction, it would get accumulated and increased in the level of conjugated bilirubin, it will also leads to the jaundice. But the manifestations are a bit different, not so much but a bit different. So jaundice is basically a syndrome which can be found in many diseases as a manifestation. So let us discuss one by one. So, but before we discuss the jaundice, I also tell you that normal levels of total bilirubin. Normal levels of total bilirubin is 1 to 1.3 milligram per deciliter. Indirect or unconjugated bilirubin is 0.2 to 0.9 milligram per deciliters, and direct or conjugated bilirubin is 0 to 0.3 milligram per deciliter. Another thing, friends, I would tell you, whenever we say there is an increased in unconjugated bilirubin, that means the obstruction was here or before that at the level of UTP glucuronyl transferase. Whenever there is an increase in unconjugated bilirubin, it causes jaundice, which is indirect type of jaundice or prehepatic type of jaundice. So through the clinical point of view, we say whenever there is the level of unconjugated bilirubin is more than 85% of the total bilirubin, we say the person is having prehepatic jaundice or unconjugated indirect jaundice. But whenever there is a problem or obstruction after the formation of conjugated bilirubin or any accumulation of this conjugated bilirubin, any obstruction in the pathways, we say the person is having posthepatic jaundice or conjugated or direct type of hyperbilirubinemia or jaundice. The person will get the manifestation jaundice, bilirubin is increased. So we say hyperbilirubinemia. But clinically again, here we say the conjugated bilirubin is increased. This direct type of jaundice, whenever we call it direct jaundice, direct type of jaundice, only when there is more than 50, the serum bilirubin level is more than 50% of the total bilirubin level. Okay, the direct bilirubin is more than 50% of the total. So friends, now we will discuss about the jaundice. Okay, what can be the reasons? So as I told you, now the jaundice can be due to the increase in the amount of unconjugated bilirubin. We say unconjugated hyperbilirubinemia, or another cause is if there is increase in the amount of conjugated bilirubin, we say conjugated hyperbilirubinemia and direct type of hyperbilirubinemia. The another thing is, what are the reasons? So just imagine a person comes to you. You, after the examination and all, you saw the sclera was yellow and skin is also pale. Leave the other manifestation, just focus on the jaundice. Sclera is yellow and the skin is pale, the person is feeling fatigued. These are, the basic symptomatology of the jaundice. What do you think of? Friends, always think, whenever this type of patient you will get in clinical practice, think of hemolysis. The most common cause of indirect unconjugated hyperbilirubinemia. Always think about hemolysis, and in hemolysis we mostly get hemolytic anemia. We always think of hemolytic anemia. Okay, now you saw that the person doesn't have the hemolytic anemia after the findings. You just saw, still you are there. The second thing the doctor must think about is the drugs, whether the person is on drugs, whether there was any underlying condition so that he is having the drugs, and these drugs have the side effect on the liver which is causing increase in the levels of unconjugated bilirubin. So these drugs can be most commonly are rifampicin, and another drug you need to remember is probenecid. Understand it? The first thing the doctor must think about, any hemolysis is going on. Okay, understandable. The RBCs are getting destroyed, and these before the lifespan, before the completion of our lifespan, the RBCs are getting destroyed. The another thing, that if this RBCs, you see in the reports that there is not significant hemolysis, you'll think about the drugs the person is having on drugs, maybe any underlying condition like tuberculosis, and he is having rifampicin, which has a direct side effect on the liver. Friends, another thing is, we can think about if the hemolysis is not taking place, if the person is not on the drugs, now still is indirect bilirubin level is more than the 85% of the total. We need to think of inherited disorders, with genetic disorders, which are Gilbert syndrome and Kigler-Najjar type 1 or type 2. I'll tell you about it. So I was telling you about the causes of the jaundice. Friends, if there is increased in the level of unconjugated bilirubin, first cause to remember is hemolysis. Second cause to think about drugs. Third cause we'll see the inherited disorders or inherited hyperbilirubinemia disorders. Now about the conjugated or direct hyperbilirubin. Conjugated means the problem or defect at the level of after the formation of the conjugated bilirubin. Maybe in the biliary tree, maybe ducts, or maybe somewhere the secretion or excretion of this bilirubin. See, the most common cause in conjugated or direct hyperbilirubinemia is bile duct disorders. Friends, bile duct disorders. First, most common is any stone in the ducts. stone, or other maybe malignancy, so that the excretion of the bilirubin is not taking place. And another reason for having the jaundice or conjugated hyperbilirubinemia is biliary tract disease. Any biliary tract disease, whenever we talk about, we think of primary sclerosing cholangitis and cirrhosis. I told you jaundice. Jaundice can be due to increased in unconjugated or conjugated. Whenever we say unconjugated, that means more than 85% of the total, the value of indirect bilirubin. Whenever we say conjugated, that means more than 50% of total, the value of bilirubin is there, we are finding. So these were the reasons of conjugated and unconjugated hyperbilirubinemia or the jaundice. See, these whenever the bilirubin levels are increased, it is also not necessary that jaundice is there to the person. Jaundice is a manifestation which can be due to underlying any disease. So now we will talk about the genetic disorders for both the cases. So friends, if we talk about the genetic disorders which are causing the increase in unconjugated bilirubin levels, so for now we think of first Gilbert syndrome. Friends, what happens in the Gilbert syndrome? A person, you just need to think as a clinical case. A person, adult person, whenever he goes to the stressful conditions, that means whether he is having an infection, whether he is on starvation or less, he is taking less calories, whether any stressful condition, fasting, he is on the fasting, this person inheritedly, organized in that way, genetically organized in that way, that bilirubin levels are more than normal. And for that person, those bilirubin levels are normal. Those bilirubin levels are not causing any harm to that person. Now, like, I'll give you the typical case: adult patient whose bilirubin levels are less than 8 milligram per deciliter. Friends, in Gilbert syndrome, you need to keep in mind through the MCQ point of view, the serum bilirubin level can never go beyond 8. Maybe you will get the patient between 2 to 3 milligram per deciliter. Maybe you will get a patient of 4 milligram per deciliter. You can get these values also. And when you take the history, you ask what is your diet, what is the condition, any infection you had, any drugs, you ask. So you will see and notice in those patients that whenever there is a stressful conditions, the level of the bilirubin increases, and everything you'll get the finding clinically, like LFT, you'll get liver function test, you'll get the histology of the liver. Maybe sometimes the doctor also tells to get the biopsy. Everything comes to be normal. So how this person is having the bilirubin levels are increased? How this person is having this bilirubin levels are increased? The thing is, this person is having the Gilbert syndrome, which is genetically the person is genetically constituted to have a little bit higher levels of the bilirubin. So we'll say, don't take stress, go home, nothing is needed really. Another syndrome, a genetic disorder in unconjugated bilirubin I was talking about is Crigler-Najjar. Crigler-Najjar syndrome has two types, type 1 and type 2. Friends, Crigler-Najjar syndrome type 1, there is no formation of this enzyme UGT, glucuronide transferase, UDP, glucuronide transferase. The enzyme is defective. Where? It was here, which was causing this conjugation reaction and formation of conjugated bilirubin. This enzyme is totally defective or deficiency. The person is having a deficiency. When this enzyme is deficient, what happens? the bilirubin levels are more than 20 in this case. Clinically, you need to also know in Gilbert syndrome, you will get the patient whose bilirubin levels can never exceed 8, sorry. It can never exceed 8 milligram per deciliter. But in Crigler-Najjar, you will see a typical case is a child having the bilirubin levels are more than 20 milligram per deciliter. Getting the point? So when this enzyme is absent, UGT, when this enzyme is absent, nothing can be done, because this type 1 Crigler-Najjar syndrome has too much higher mortality rate, and the death of the child can occur within 1 to 2 years. You need to keep in mind death of the child occurs within 1 to 2 years. Gilbert syndrome, adult patient, genetically constituted to have higher levels of the bilirubin. In Crigler-Najjar type 1, more than 20 the levels of bilirubin, and death and deficiency of UDP, GT. Friends, nothing much we can do over here for the Crigler-Najjar. We just tell the patient to have the liver transplant. Nothing can be done more in Crigler-Najjar type 1. In Crigler, now another type I told you, Crigler-Najjar syndrome has two types, type 1 and type 2. In type 2, what happens? UGT is present, but it is not working. It is working just less than 10%. Less than 10% of this enzyme is working. You're getting my point, friends? Less than 10% this enzyme UGT is working, and you will get in these patients the bilirubin levels is near 7 to 10 milligram per deciliter. Everything comes normal. LFT for liver biopsy and all, histology, everything comes normal. But we have one thing is there, we have positive barbiton response. Positive barbiton response, what is it, friends? See, in these patients, we know we have the deficiency, not completely, the deficiency of enzyme UGT. So we give one anti-epileptic drug which is known as phenobarbital, which is phenobarbital. Mind it, friends, it comes under the category of anti-epileptic drugs. But the thing is, this drug is one of the enzyme inducer. The characteristic point, this drug is enzyme inducer. So it increases the activity of UGT. With that, we will get the activity of UGT, and conjugated bilirubin and pathways can be the problem of defective pathways can be solved here. Else everything comes normal. One more thing you need to keep in mind about Crigler-Najjar type 2, there is pigmented bile in the duodenum. We will find the pigmented bile in the duodenum. See, if we talk about the reasons, genetic reasons of conjugated hyperbilirubinemia, one we get Dubin-Johnson syndrome, and another we get Rotor syndrome. Dubin-Johnson, and another we get Rotor syndrome. Friends, what happens in the Dubin-Johnson syndrome pathologically? There is a gene in the body which is ABCC2 gene mutation. The mutation, the sudden spontaneous changes occurs in the genetic constitution of a person. This is known to be the mutation. What happens in Dubin-Johnson syndrome? There is a mutation of the ABCC2 gene and defective MRP2 molecule. Defective MRP2 molecule. Friends, in the pathway of bilirubin metabolism, I have told you one molecule, OATP, which is causing the unconjugated bilirubin to enter inside. Another molecule I told you in the last video also, MRP2. This MRP2 causes the release of bilirubin into the biliary ducts. And if this is defective, if MRP2 molecule is defective, the release of or the transport of bilirubin into the ducts will be defective. Defective transport of bilirubin into the ducts and into the bile, right? When this is defective, we find dark and pigmented liver. What we find? Dark and pigmented liver. And we see, the thing is, why do we find the dark and pigmented liver? Because this is the metabolites of epinephrine, defective metabolites of epinephrine. Metabolites of epinephrine. Friends, we will understand in the biochemistry point of view also, when the metabolization of epinephrine is defective in the Dubin-Johnson syndrome. Now, here also the LFT is normal, but dark pigmented liver you will get over here. The bilirubin levels near 4 to 7 milligram per day fall in the category of 4 to 7. The patient is totally asymptomatic. So the doctor, after the his physical examination, history and all the things, we get what we get. One thing we have, which is urine corpoporphyrin. The levels of the type 1 corpoporphyrin, urine corpoporphyrin, is more than the type 3. Normally what happens? This levels type 3 is more than type 1. But here in Dubin-Johnson, the type 1 is more than type 3. The another syndrome, which is Rotor syndrome. In Rotor syndromes, what happens? The levels both 4 to 7. Here also 4 to 7. Good prognosis. Here you can also, the patient is asymptomatic, you will still can make the person correct. Here the defect in the Rotor syndrome is in OATP molecule. OATP molecule, I told you, organic and transport protein. Another thing is, here urine corpoporphyrin level type 1 is more than type 3. Okay, similarity is there. Here type 1 is more than type 3. But the total urine corpoporphyrin level is increased over here. But over there, the total is normal. These are the distinguishing features which a doctor keep in mind while writing the diagnosis. Before writing the diagnosis, the doctor must be so skilled and trained, after looking at all the physical examination and history of the patient, after looking at the reports and everything. But the main difference is that after we'll get the reports in the Dubin-Johnson, we'll get a dark and pigmented liver because of the metabolites which has been released from the epinephrine. But here the liver histology is normal. We don't get any dark or pigmented liver. Friends, for Dubin-Johnson and Rotor syndrome, one test is also there, which is known as bromsulfathine test. This substance is being given to the person to differentiate Dubin-Johnson and Rotor. I'll tell you. This substance is given to the person after 45 minutes, exactly at 45 minutes, we see the levels of this molecule which we have given to the patient. After 45 minutes or at 45th minute, we'll see the level of this molecule inside the patient. And we'll see at 120 minutes. If this molecule has the quantity more at 120 minute than at 45th minute, we say this test is positive. And in Dubin-Johnson syndrome, this test is positive. Okay, but in Rotor syndrome, this test is negative. You got it? We give the person bromosulfathine, a molecule. We'll check the blood levels, how it is being getting distributed. Okay, at 40, if the level of this is at 120 minutes is more than the level at the 45th minute, this test is known as positive test. Okay, and this is positive in Dubin-Johnson syndrome. The differentiating feature between Dubin-Johnson and Rotor syndrome, urine porphyrin level, and this liver pigmentation, dark and pigmented liver, will get in Dubin-Johnson. And this bromosulfathine test, it is negative in Rotor syndrome. So This is all about the jaundice, the pathological aspects, the reasons. Just revise it, keep revising, keep studying. Best of luck.